Hello all, this is a part 2 of Chapter 13 on therapies. In part 2 of the video, we will discuss different types of action therapy, specifically behavioral and cognitive therapy. Before diving into behavioral therapy, do you remember how behavioralism view behavior? In other words, how do behavioralism explain people's behavior? For example, being scared of heights or a snake, or explain how dogs are able to do tricks. We talked about it through classical and operant conditioning. So all of the behaviors are learned through these conditionings. According to the traditional behavioralism, people do not have free will and all behaviors have been learned from our previous experiences. And these behaviors that were learned are specific to a certain situation. So if the environment or a setting changes, people may not behave in the same way. So how does this apply in therapy? This means that if behavior is learned, then abnormal behavior is also acquired and learned. Also, if a behavior is situation specific, then therapy should also be tailored to a specific situation. So in a behavioral therapy, therapists play an active and directive role, basically playing a role of a problem solver. As a result, it is more like a problem-solving relationship, where the therapist may act similar to a coach or a teacher, and the client acts like a learner or a student. And these styles are pretty different than person-centered and psychoanalysis, or psychodynamic psychotherapy. So how different is it? Behavioral therapy is different from person-centered, which takes a non-directive approach. Behavioral therapy is also different from psychoanalysis, where the focus is not necessarily solving the problem, but on revealing the unconscious, which the behavioral therapist has minimal interest in. So one of the techniques in behavioral therapy is exposure therapy, which can be used to treat anxiety-related disorders and other types of psychological disorders, like phobias and depression. The underlying assumption of exposure therapy is that clients have not learned that situation. For example, snakes, if an individual has snake phobia, are harmless. So what happens in therapy is that the therapist attempts to decrease the level of anxiety by breaking the pairing from classical conditioning. And I know that it has been a while since we talked about classical conditioning, but do you remember what it was? If not, no worries. This is a review of classical conditioning. Unconditional stimulus, UCS, is a stimulus that produces a response without prior learning. For example, we do not need to learn to elicit fear or pain after getting bitten by a dog, for example. As a result, the response of fear or pain is called the unconditioned response. Because again, we did not have to learn that getting bitten by a dog would lead to pain. We naturally know that. But because an individual was bitten by a dog, this individual may develop a dog phobia, and just by looking at any dogs may elicit the same response of fear or pain. Although the responses are the same, the pain responses that was elicited due to the presence of a dog is called the conditioned response. The dog in this case is the conditioned stimulus because before the unconditioned stimulus occurred, the presence of conditioned stimulus alone would not have elicited any responses, and we use the term neutral stimulus to refer this. But after getting bitten by a dog, we learn to elicit the same fear and pain responses just by the presence of a dog. So earlier, we talked about breaking the pairing. So what do we mean by that? The purpose of exposure therapy is to remove this arrow, so that the conditioned stimulus will no longer elicit any pain and fear responses. Essentially, the chain between conditioned stimulus and conditioned response is the cause of phobia. And we cannot change the relationship between unconditioned stimulus and unconditioned response because, again, they are naturally occurring responses. So what actually happens in exposure therapy? There are various choices in exposure therapy. First, it can be imaginal or in vivo. In vivo exposure is where a client is directly facing a feared object, situation, or activity in real life. For example, someone with a fear of snakes might be asked to hold a snake. But in imaginal, then the client is asked to imagine, for example, holding a snake. This can be done step by step, or it can be done all at once, which is called flooding or implosion. This is where a client is straight out asked to hold a snake. But as this can be overwhelmingly stressful, there is a way to gradually expose these stimulus, which is called graded exposure. And usually the therapist and the client will develop what is called a fear hierarchy, basically listing the stimulus in order from the least anxiety-provoking to the most anxiety-provoking. So this is an example of fear hierarchy for an individual with spider phobia. As you can see, the first half are mostly imaginal exposure, and as the fear rating gets high, it will turn into vivo exposure, which just makes sense, right? And note that this is very important to develop collaboratively between the therapist and the client, because what can be fearful depends on the client. For example, if bitten by a spider on the foot, crawling on the shoe may be more anxiety-provoking than having a spider crawl on your sleeves. Another related method to exposure therapy is called systematic desensitization. But the main difference is that as opposed to breaking the pairing, like in exposure therapy, it attempts to repair or counter condition. So let's see what this means. So if you remember from the previous example, a presence of a dog led to a response of fear. It is similar to exposure therapy in a way that we want to remove this link or association. But what's different is that in systematic desensitization, we are replacing with a different response, such as being relaxed, even in the presence of conditioned stimulus. But why replace with a relaxed state? Because we know that a relaxed state is incompatible with anxiety. In other words, if we are relaxed, we cannot be anxious at the same time. So how does it work? The procedure is quite similar to exposure therapy, but with one major difference. The first step is to teach ways to become relaxed, and there are many ways to do this, such as breathing slowly and using guided imagery, which involves picturing a relaxing scene, like a beach. And then it kind of goes back to the procedure of exposure therapy, where the therapist and the client will collaboratively build fear hierarchy and work on from the least to most fear-provoking stimulus. But as the client is able to use relaxation techniques, they will be asked to use these skills whenever their anxiety increases as they work on the fear hierarchy until they are experiencing minimal anxiety. Even, for example, when thinking of a spider or holding a box with spider. Alright, so next we will move on to the cognitive therapy, which focuses on our thinking patterns and our belief system. So why do we need to focus on these? Because depending on our belief, we would often experience different behavioral and emotional consequences even when experiencing the exact same event. For example, say that you got 80 on your next exam. And there may be people who are very excited, or very frustrated, or kind of in a shock, or just indifferent. So why are there various reactions even when it was exactly the same event? Again, because our belief and expectations are different. So cognitive therapy adds cognition and thoughts to behavior, and it is based on the assumption that our cognitions, emotions, and behaviors interact, such as, again, in the case of getting an 80 on that exam. And because of this, cognitive and behavioral therapy are often combined, and it is called cognitive behavior therapy, or CBT. But from the perspective of cognitive therapists, the focus is on irrational and illogical thinking styles, such as all or nothing thinking or overgeneralization. So one approach that is quite similar to the idea of CBT is called Rational Emotive Behavior Therapy, or REBT, which is built on the ABC theory of personality. So using the same example of getting an 80 on the exam, this event is the activating event. But again, we know that depending on the belief, the emotional and behavioral responses would differ quite greatly. So for example, if an individual has a belief that he or she have to get straight A's to get into medical school, then the emotional and behavioral responses may include feeling disappointed, maybe wanting to vent to his or her friends, or just use other coping strategies. But RABT does not end here, and there are actually D and E. And this is where the intervention happens. So is it really true that this individual would need to get straight A's to attend medical school? In other words, did all individuals who attended medical school had all straight A's? Probably not. Also, getting 80 on the exam does not mean this student will get a B or lower in the final grade. So this process includes disputing and challenging the individual's belief. And the last step is to come up with an effective new belief, which may be believing that getting 80 is not the end of the world. And the important thing is to develop a new belief that is more accurate and stop being so critical about themselves. So to recap, the goal of cognitive therapy is to reduce the tendency to blame self or others for wrongs in life. Because the more we criticize ourselves, we probably have a very high standard, which might be very difficult to accomplish, and as a result, we might feel more depressed or anxious. So we want to be kind to ourselves and also to others as well. We also want to effectively deal with future events. Effectively means that, for example, we don't want to get bogged down on a single event that went wrong where there might be other areas in our life that are going really well. We can't predict what will happen in the future, so we don't want to overly worry about something to the point we cannot focus on the present. And similar to behavioral therapy, the relationship between the therapist and the client, or the therapeutic alliance, is needed, but that is not the main focus here. And this means that there is no techniques. There's no techniques to build therapeutic alliance. Whereas in person-centered approach, many of the therapist's attitudes, like being a non-judgmental listener, genuineness, providing empathy, and unconditional positive regard, are known to facilitate therapeutic alliance. So what are some of the techniques used in cognitive therapy? As discussed in the REBT, disputing irrational belief is commonly used in cognitive therapy. Also, many therapists have clients keep track of their own irrational beliefs and also dispute on their own needs when needed. Of course, in order to do this, a client do need to be able to recognize the irrational belief themselves, which does typically take 2-3 sessions. Also, it's important for the client to avoid using words like should, must, ought to. If an individual uses these terms, then typically they have a quite fixed mindset about certain things. Like, for example, I have to get straight A's to get into medical school. This tends to overly increase anxiety or depression, and obviously will not be developing a tolerant philosophy of life as we talked in the previous slide. And last, we discussed the pros and cons of both behavioral and cognitive therapy, as they share many of them. One contribution is that they are very efficient and goal-oriented and can be conducted in shorter sessions. And specific techniques have been developed in treating specific disorders. For example, there are independent treatment manuals in treating different psychological disorders like phobias, anxiety disorders, major depressive disorders. So it becomes pretty handy for the therapist. But like other psychotherapies, there are limitations. First, the goal is to fix problems, but it does not encourage inner growth. In other words, it works pretty well in reducing symptoms, but it does not, for example, assist individuals to achieve self-actualization, like in person-centered psychotherapy. Next, it does not deal with vague or existential problems. Again, the goal is to reduce symptoms. So the main focus will not be answering questions like, what is the meaning of life? And last, kind of summarizing what I just said, can everyone benefit out of it? The answer is no, just like in other psychotherapy as well. There are clients who would be a very good candidate of CBT, but there are people who would not be, which is probably why so many therapists uses different techniques from various psychotherapies. So that's all I got for Chapter 13 on therapies. Hopefully it was helpful for you to understand different techniques used in behavioral and cognitive therapies, and how those are different from psychoanalysis and person-centered psychotherapy, which we discussed in part 1 of the video. As always, if you have any questions, let me know. Thanks and take care.